Hi everyone, welcome to Chalk Talk Med, where we cover high-yield medicine topics for students. In this video, I'm going to be talking about hemolytic disease of the newborn. It's also known as hemolytic disease of the fetus and newborn because it can cause problems in the fetal period as well before birth. And finally, another name you might see when you're studying is erythroblastosis fetalis, though this one is an older name that is rarely used anymore, but you might see it come up in some questions or study materials, so I'm just including it here so you don't get confused. Anyway, regardless of which name is used, it's a very important cause of neonatal jaundice. It falls in that category of rare but life-threatening, so it's important to learn it well. And of course, it's very high yield for exams. So let's get started. All right, so let's take a quick look at our outline. We're going to start with a little mini flowchart I've put together about neonatal jaundice and see where hemolytic disease of the newborn fits in. Then we're going to specifically talk about HDN and it's how to make the diagnosis. There are two main causes, ABO and RH incompatibility, so we're going to get into it here. And then we're going to end it talking about clinical findings and treatment with a special slide on ROGAM. Okay, so one of the most common presentations of hemolytic disease of the newborn is going to be as a manifestation of a newborn with neonatal jaundice. So let's see how that fits into this algorithm. I've created this little mini algorithm. The goal here is not to have every single diagnosis of neonatal jaundice on here. This is just focusing on more of the higher yield stuff and the ones that you can easily categorize here so that we can get down to our final diagnosis, which is hemolytic disease of the newborn. So I'm going to walk us through here. So let's say you have a newborn that starts with neonatal jaundice. That means it's a newborn with jaundice, which is due to high bilirubin levels. Then the first step is, are these bilirubins unconjugated bilirubin? So is this indirect hyperbilirubinemia or is it conjugated, aka direct hyperbilirubinemia? If it's conjugated, aka direct, that means that the problem is due to impaired excretion of bile. That's why you can't get rid of the conjugated bilirubin. And some of the major diseases I've included here, so biliary atresia, liver disease, and then a couple of your inherited hyperbilirubinemias, Dupin-Johnson and Roeder. But we're going to be working over here because this is more relevant to our talk today. So you have high unconjugated bilirubin levels. The conjugated bili is fine. And there's really only two reasons for this. Number one, you're generating too much unconjugated bilirubin, which is due to hemolysis. And number two, you have impaired conjugation. So there's a problem with the UGT enzyme. So you're not able to conjugate the bilirubin. Therefore, you have high levels of unconjugated. And when you're in this category, then the next thing you can think about is this due to a hemolysis problem or is this not a hemolytic disease? So if this is not a hemolytic disease, then you're going to have a normal hemoglobin hematocrit because there's no anemia and red blood cell destruction. And the reticulocytes, so the immature red blood cells, are going to be normal because there's no reason for your bone marrow to be revving up. And so our non-hemolytic diseases are benign neonatal hyperbilirubinemia. This is also known as physiologic jaundice. And compared to all of these causes, this is the most common cause of neonatal jaundice. And then, of course, you have breastfeeding or breast milk jaundice, and then a couple of your other inherited hyperbilirubinemias, so Gilbert's and Crigler-Najjar. And I have separate videos that talk about all of these conditions. But what we're talking about here today is going to be if there is hemolysis. So if the jaundice is caused by hemolytic disease, then you have two very important clues here. You're going to have a low hemoglobin and low hematocrit. That's due to the red blood cell destruction, which is hemolysis. And in response to that, your bone marrow is going to rev up to generate more red blood cells. Therefore, there's going to be more immature red blood cells, aka reticulocytes, floating around in your bloodstream. Therefore, this anemia is going to be associated with a high reticulocyte count. And this is the classic key finding for hemolytic diseases. So now we're over here. Let's say we have all of these findings. So now once we have a hemolytic disease, there's only one final question. Is this hemolysis due to an inherited red blood cell mutation? For example, the red blood cells here are defected and mutated due to an inherited condition such as hereditary spherocytosis or sickle cell disease or G6PD deficiency. So this newborn is essentially born with an inherited problem with their red blood cell that's causing the hemolysis at birth. Or are the red blood cells themselves, quote unquote, normal, meaning there's no mutation, there's no inherited problem, but they're being lysed anyway? And the main condition that would do this and cause neonatal jaundice at this stage would be hemolytic disease of the newborn, which is what we're going to be talking about. Okay, so let's learn about hemolytic disease of the newborn. What causes it? The main problem is you have maternal antibodies. So these antibodies in the maternal circulation are formed against antigens on the surface of the fetus's red blood cells. And these antibodies have to cross the placenta, so they can only be the IgG class, because that's the only class of antibodies that can actually cross the placenta. And what they do is they cross over and they bind these antigens on the surface of the red blood cells, as shown right here. And once they bind, they cause direct destruction of these red blood cells, and that's how they lead to hemolysis. And as you know in immunology, this is known as a type 2 hypersensitivity reaction. So this disease is a classic example of a type 2 hypersensitivity. There are two main types of this condition because there are two main classes of red blood cell antigens, and those are shown here. So type 1 is the ABO hemolytic disease because it happens against the ABO antigens, and then type 2 is the rhesus hemolytic disease because it's formed against the Rh antigen on the surface of the red blood cells. And I'm going to go through these in a lot more detail in the next upcoming slides. But first, let's go through how you're going to make the diagnosis of hemolytic disease of the newborn. So let's say you have a test question, you have a neonatal jaundice, for example, and you're entertaining this diagnosis. My approach would be in step 1, confirm hemolysis, right? First, look at those things that we talked about on the prior slides. So the 3 findings are high indirect bilirubin, low hemoglobin, and high reticulocyte count. So these clues will tell you, okay, so this patient has hemolysis. So your next question is this an inherited hemolytic condition like sickle cell, or could this be an immune-mediated condition such as hemolytic disease of the newborn? And the way you're going to be able to tell the difference is by a positive direct Coombs test. A positive direct Coombs test tells you that those fetal red blood cells do in fact have maternal antibodies coated on their surface. Therefore, it is consistent with hemolytic disease of the newborn. This test would not be positive in those inherited mutation conditions such as sickle cell, hereditary spherocytosis, etc. And I have a separate video talking about Coombs test that's in the hematology playlist, so you can check out that video to learn more about the direct versus indirect Coombs test. And finally, the last step is just to confirm there should be a blood mismatch between mom and fetus that's causing this problem. So either there should be an ABO or Rh mismatch between mom and fetus that's generating the creation of these antibodies. All right, so we've learned what hemolytic disease of the newborn is. That's half the battle. The next part is to learn about the two types, which are ABO incompatibility versus rhesus incompatibility, and be able to distinguish them. And so I'm going to start with ABO incompatibility here. I'm going to go through the blood type system first, because once you learn this, it'll make it easier to learn about what the disease is going to look like. So the ABO blood type system, this is what you're already familiar with. You may know your own blood type. So there's 4 major phenotypes: A, B, ABO, and O. So if you're blood type A, for example, you're going to have the A antigen on the surface of your red blood cells. If you're type B, you have the B antigen. If you're AB, you have both. And type O, you have neither antigen. Now, what's important here, one of the key kind of weird and strange things about this is that, first of all, these are called antigens because our body will form antibodies against them if it recognizes them as non-self. The other thing that's weird is that these antigens are not just on the surface of the red blood cells, but they're actually found commonly in the environment. For example, many food and bacteria. So that means that even as little babies, we're ingesting both the A and the B antigen in our diet. And so what's going to happen is that even as a 6-month-old or a 1-year-old, you have already started forming antibodies against whichever one of these antigens is in your own. So to make it perfectly clear, let's say your blood type is A. That means by the time you're 6 months or a year old, you have already started forming antibodies against the B antigen. You already have that circulating in your blood. Same thing if you're B, you have antibodies against A antigen. If you're AB, you're going to have no antibodies because you're going to recognize both of those antigens that you ingested as self, so no problems for your immune system. Blood type O, which I am, I have already started forming antibodies against both, so I recognize both of them as non-self. So this is important. That means sensitization here, which is the formation of antibodies and that first exposure, occurs during childhood. So by the time adulthood comes on or by the time the first pregnancy happens, you've already been sensitized, immune system ready to go. The last point here is that the antigens are oligosaccharides, fancy term for carbohydrates. That means they're not proteins. That's the important things. That means that they're going to only generate an IgM response, very weak IgG response. Remember, IgG is the only type of antibody that can cross the placenta, so that is going to account for the weak and mild symptoms of this disease. And speaking of the disease, let's talk about it now because I think we're ready. So it's called ABO antigen incompatibility. Incompatibility here means that there's a mismatch between the ABO antigen between mom and fetus. So usually the maternal red blood cells are type O, and that should make sense because they make antibodies against everything. And the fetal red blood cells are type A, B, or AB, and that should make sense because they're making some kind of antigen for which this is going to attack. Now, one of the important things that test questions want you to know in contrasting between ABO and Rh disease is that this one, the hemolysis, can occur in the first pregnancy. And that should be easy now to know because you've been previously sensitized during childhood. I said that earlier, so now you already have circulating antibodies. First pregnancy happens. If there's a mismatch, antibodies are already present and can potentially cross over and cause hemolysis. And in fact, it is a pretty common thing to have this type of mismatch and hemolytic disease of the newborn. But thankfully, the symptoms are usually very mild or even no symptoms. Clinical significance is rare here, and that's because of what we talked about. Because of these carbohydrate antigens, there's a much weaker IgG response. Therefore, hemolysis is less severe and symptoms are very mild. This is going to be major contrast to the Rh incompatibility that we're going to talk about next. All right, so now let's talk about this Rh incompatibility. Rh stands for rhesus. You also see Rhd, and D here stands for the D antigen. So we had the A and the B antigen for the last one, and we have the D antigen here. I'm not sure what happened to the C antigen, but anyway, we'll move on. So we're going to start with the blood type system first. So the rhesus D antigen system here, this is more straightforward or easier because there's only two phenotypes. So if you have the D antigen, then you're Rh positive, and if you don't express the D antigen on the surface of your red blood cells, then you're Rh negative. And you may have heard someone say they're O positive or B negative. The positive and the negative is referring to this, the rhesus antigen system. One important difference here is that these antigens are not found in food or bacteria or the rest of the environment. So the only way that sensitization happens, which means that initial formation of antibodies on that first exposure, is by being exposed to Rh positive red blood cells. And the only way this happens is either by getting a blood transfusion from a donor that was Rh positive, that's straightforward, or from a prior Rh positive pregnancy. So in other words, if you were pregnant with an Rh positive fetus, you could potentially get exposed to the Rh positive fetal red blood cells, and that could cause sensitization. The way that this happens is that in that first pregnancy, there's no circulating antibodies, so that first pregnancy is fine. But at the end of the pregnancy, during delivery, there's going to be some maternal fetal hemorrhage that happens, and some of those fetal red blood cells can cross over to the maternal circulation and sensitize it, and then they will form circulating antibodies that are going to be present now, and they're going to affect subsequent pregnancies. The final thing that's different here is that these antigens are not carbohydrates, they're proteins. That means that they are going to generate a strong IgG response, which can cross the placenta and cause major hemolysis. So now let's talk about the disease. So this is rhesus antigen incompatibility. So here incompatibility again means that there's a mismatch between maternal and fetal red blood cells. So here, the maternal red blood cells are going to be Rh negative, and the fetal red blood cells, of course, are going to be Rh positive because they're carrying the D antigen. One important thing to contrast here from ABO incompatibility is that this one does not occur in the first pregnancy, meaning hemolysis does not occur in the first pregnancy. So let's think about why that is and reason through it. In ABO incompatibility, we did have hemolysis in the first pregnancy because we had sensitization during childhood, previous exposure to all these environmental antigens that had A and B on it. But remember that this antigen is not found in the environment, so the only way you're going to get sensitized and exposed is from being exposed to the Rh positive red blood cells, usually in that first pregnancy. Therefore, what happens in the first pregnancy usually is sensitization and development of those antibodies that are then going to cause hemolysis in subsequent pregnancies. Now I have an asterisk here just to remind us that there's one exception, and we've already kind of talked about this. If mom has already received a blood transfusion that happened to be from a Rh positive blood donor prior to that first pregnancy, then they would have circulating antibodies. Otherwise, this Rh incompatibility does not cause hemolysis in the first pregnancy. That's when sensitization happens, and then hemolysis occurs in subsequent ones. So now let's talk about disease severity. So we said in ABO incompatibility, there was no symptoms or very mild symptoms. This one can range from mild, but it can also be very severe. So this is the worrisome, dangerous hemolytic disease of the newborn, the Rh incompatibility one. And this can cause severe hemolysis and even severe life-threatening anemia, which is known as hydrops fetalis. And I'm going to talk about that shortly. And the final point is that thankfully this one is much more rare, and this is mostly due to prevention by administering something called ROGAM, which I'm also going to talk about shortly. All right, so now let's talk about the clinical findings and the treatment of hemolytic disease of the newborn. So we'll start with the clinical findings, and there are three major things to go over here. So number one, of course, is anemia because of all the excessive red blood cell breakdown. And this can be either mild, for example, an ABO incompatibility, or it can be severe, as in the Rh hemolytic disease. Now, this most severe and life-threatening form of anemia here is known as hydrops fetalis, and this can occur as a consequence of any severe anemia, not just HDN, but it's commonly seen here in the severe form. And what happens here is that due to the severe anemia, you have very limited oxygen carrying capacity in this fetus. So in order to compensate for that, the fetus's heart goes into overdrive, and what ends up happening is what's known as high output congestive heart failure. And therefore, the clinical manifestations are going to be exactly what you expect to see in congestive heart failure, which is fluid accumulation and edema. So the findings here are going to be a fetus with diffuse edema, pleural and pericardial effusions, and ascites. Now the name here can be helpful because fetalis means it's happening in the fetus, and hydrops, the hydro makes me think of water and reminds me that there's water and fluid accumulation as the main manifestation here. Unfortunately, this disease is very, very severe and usually not compatible with life. The second clinical finding is something known as hepatosplenomegaly, so enlarged liver and spleen, and this also occurs if there is severe anemia. So here, if there's severe anemia, the body's going to try to compensate by making more red blood cells. First place it's going to tap into is the bone marrow, obviously, but eventually it's going to realize that this anemia is too severe and I need to tap into my extra resources. The only other two organs in the body really that can make red blood cells, which are the liver and the spleen, and therefore this is known as extramedullary hematopoiesis. That means generation of red blood cells outside of the bone marrow. And as a result of this activity in the liver and spleen to try to generate more new red blood cells, they're going to be enlarged. So this is an important clue, especially on exam questions, to pay attention to for severe hemolytic disease of the newborn. And finally, jaundice. So of course, remember going back to the very beginning, this was one of the things on our differential diagnosis for neonatal jaundice. And again, depending on the severity of the disease, the bilirubin level can be mild or severely elevated. And if it's very high, the problem is that it can cause kernicterus because it's unconjugated bilirubin. One important clue to pay attention to here, again, especially for exam questions, is that classically physiologic jaundice onset is after the first 24 hours of life, whereas hemolytic disease of the newborn onset is within or before the first 24 hours of life. So pay attention to the onset of jaundice here. If it's early onset, it's more consistent with hemolytic disease than physiologic jaundice. Okay, now let's talk about the treatment. And this is pretty straightforward because you're just treating what the underlying problems are. So one of your main problems is severe anemia. So how can you treat that? You transfuse red blood cells. The other problem is you have very high levels of unconjugated bilirubin. So how do you treat that? Primarily with phototherapy. If the levels remain high, then you have to actually do exchange transfusion to remove the blood with unconjugated bilirubin in it. And then the final treatment that's unique to this condition is something known as IVIG. So this is intravenous immunoglobulin. And this immunoglobulin is actually an antibody directed against the maternal antibodies that are causing the problem. So they're going to actually bind and neutralize them to mitigate the severity of the condition. Okay, so the final important topic to discuss here is something that's very high yield clinically. This is known as anti-D immunoglobulin, also known as RhoGAM. So based on the name, you can tell that this is an antibody against the D antigen, which is responsible for the Rh positive status. So of course, the goal here is to prevent the rhesus hemolytic disease of the newborn. And that's important because as we talked about, this is the severe form that's life-threatening. Now, the way that this works is that Rh negative pregnant people get injected with this anti-D immunoglobulin, and this is an immunoglobulin that's now going to circulate in their bloodstream. It's going to stay in the maternal circulation, not going to cross over, and it's essentially just going to survey for the presence of Rh positive red blood cells in case the fetus is Rh positive. So in case this Rh positive fetal red blood cells do cross into the maternal circulation, for example, during delivery, before they get a chance to activate the maternal immune system and cause the formation of these antibodies that are going to now cause problems in the future, they're going to get neutralized by this injected antibody, by this RhoGAM, and therefore there's not going to be generation of maternal immune antibodies, and this is going to prevent sensitization. So what this means is that the pregnant person is not going to develop this anti-D antibodies, and therefore Rh positive fetuses in subsequent future pregnancies are now going to be protected against hemolytic disease of the newborn caused by the rhesus antigen incompatibility. All right, so that's pretty much it for hemolytic disease of the newborn. One of the things that I emphasize in this talk that's important for you to know is the difference between ABO and Rh incompatibility. And so sometimes when you have these compare and contrasts, it's helpful to have a nice little organized table that compares these things with each other. So that's what I've created here for you guys, and I want to share it with you here. So the top row is ABO incompatibility, the key features of it and what it looks like. And of course, the bottom row is the Rh one. So you can feel free if you want to just pause the video and look through it here to make sure it all looks good to you and you understand it, or you can also just feel free to screenshot it and keep it as reference for future use. You can use it however helps you best to study. Okay, that's it and that's all. If you enjoyed this video and you want to learn more about this topic, check out these related videos that I've linked here. You can also search this channel, Chalk Talk Med, for other topics to see if they're covered. And if there are other videos that you want to see or you'd like to just give some feedback, please feel free to drop your thoughts in the comment section. But thank you for watching, and I'll see you next time.